So, osteoporosis, we know for 30 years that osteoporosis rely on two things, on the density itself and on the microarchitecture. Yet, we didn't have any tool to really measure the microstructure in a daily routine. So is it really important? Actually, it is, because we know that a lot of fracture occurred in a non-osteoporotic zone. And why that? Because you can have exactly the same density, but the underlying structure could be quite different. So that's why measuring the structure of the bone on top of the density is very important. So having said that, we have developed the TBS, stand for Trabecular Bone Score, that extracts microstructural information from a 2D image that been used according to a modified experimental variogram that we used from geophysics. And then we optimize the choice that we have to make through artificial intelligence to optimize the outcome of the TBS. So what we have that is you can have exactly the same density, and then what we'll have is the underlying structure can be different. And if you have the same density, different structure, one be more solid than the others, then obviously, medically speaking, you will take a slightly different pathway for given patients. So practically, it's installed on a DEXA systems. You will have the DEXA analyzed from the spine. Within few seconds, you will have a full report, including the TBS, the level of risk and everything. So it's totally seamlessly integrated into the workflow. TBS is strongly correlated to microstructure, independently of the density and the structure, that it predicts a fracture independently, again, of the density and of structure and FRAX. And that means it helps fine-tuning the level of risk for the management of the patients. On the second thing is also help in a grade level zone when we talk about osteopenia and also in secondary osteoporosis and so on. So when we have all that together, let's see how we can use that in a clinical practice. First of all, if you take the first study that we had at the beginning, it was from Manitoba, based on more than 33,000 patients, so the largest study ever in osteoporosis. And what you can notice here, if you combine the minimum BMD T-score for the diagnostic of osteoporosis with the lowest tertile of TBS, if you have a low structure and osteoporosis, you have a very high risk of fracture that will identify patient most likely fracture very soon. Reversely, if you have a normal density and a normal structure, the risk of fracture is extremely low. But the one which is very interesting, if you have osteopenic and low structure, the level of risk is equivalent to what we found in osteoporosis. Why those patients, usually we don't treat them because they don't reach the threshold of osteoporosis. And that's where we have the most largest overlap between fracture and non-fracture. So practically, if we project those into things, you see the level of risk that we are seeing here are pretty much equivalent, and we improve the accuracy of the DEXA by roughly adding about 20% accuracy on top of the current accuracy of the DXA, which is pretty huge for clinical practice. So obviously, if you have someone with osteopenia and a low structure, you have to wonder why. Is there is underlying cause of osteoporosis and stuff like that? So you will just try to find the reason why the patient is very high risk. So one of the things when you combine the density and the structure is one thing, but you know we all have FRAX now. So can TBS add on top of FRAX? So the similar analysis based on a meta-analysis have been done by the McCloskey group and John Canis and so on from the FRAX group. And what they found is if you have the highest tertile of probability, a high probability of fracture, combined with low TBS, you even further increase the risk of fracture, meaning that you have an additional value of TBS. And you see an example here where you have a patient with a 21% probability of fracture. Depending on the TBS value, you will increase your probability of fracture from 21 to up to 35. Or potentially you can reduce the risk if the structure is good. So you start to leverage the structure and the density to better fine-tune, characterize the level of risk of your patients. So does it work on all type of patients? The answer is Obviously, no, if you have a very low probability, the TBS will not reverse the things. But if you're focusing around the intervention threshold, then you can have an impact almost on one patient out of four, meaning 25% of the patient which start to be substantial. So now, which is also very important, is it's pretty often that TBS, the FRAX is not used for treatment initiation because insurance doesn't recognize FRAX as a criteria to start or reimburse treatment. Still, a lot of countries use the BMD T-score. So what we did for FRAX, we did that also for the BMD T-score, where we adjust the BMD T-score by the TBS to have kind of a BMD T-score adjusted by TBS. So the BMD T-score will take into account the microstructure through the T-score. And you can see the same here. You can have a patient with a minus 1.5 osteopenic. If the TBS is very low, that will make it an equivalent maybe of a T-score of -3 or something like that, which is quite also important where countries don't use the FRAX to initiate the treatment, for example, or to enter in other model, for example, the FRAX, Italian FRAX, which is a Fracco di Fracco. You can enter the BMD T-score adjusted by TBS into the model of the Italian side, and you have the structure taken into account in another model than the one for FRAX, for example. So having said that, another interesting features is that different treatment will impact the density pretty well for pretty much all patients. But all treatment do not impact the microstructure of the bone, meaning that if you have anabolic drugs, like a PTH or even romosozumab, for example, or PTH or PTH analog, you will increase the density and the structure. Now, if you have a biphosphonate, biphosphonate is not supposed to increase the microstructure of the bone. It's supposed to increase the degree of mineralization. It will increase the density, but will not increase the microstructure of the bone. But it will maintain the structure. While some other MHT, for example, or raloxifene, they will slow down the loss of microstructure. It will not even maintain the structure. It will be negative maintenance, rather biphosphonate be positive maintenance, but not. Now with denosumab, it will be something a bit in between. But now it's just been published just a couple of days ago, a long-term data on denosumab up to 10 years, and then you will increase the structure of the bone over 10 years, meaning you will have a similar effect that a PTH or PTH analog if you treat the patient long-term. So, second osteoporosis, I will not go into that because there is hundreds of papers, but it really covers different variety of pathology from agrology, rheumatology, gynecology, geriatric, oncology as well. So overall, the structure of the bone is decreased when you have second osteoporosis. And one of the good examples is diabetic, and I will show you a clinical case at the end. So how do we bundle all the things I said into clinical practice? And that's a workflow that's been proposed, for example. First of all, you have an indication of use, which is the same as DXA, obviously. Then after, you will have to do image acquisition. You will have to check for the bone health assessment. And then you have the part which is about treatment. So let's go part by part. So I will skip that one. It's mostly keep the context of GIGO, garbage in, garbage out, okay? If you don't do a good DEXA scans, then the TBS cannot be good as well, nor the BMD, nor the TBS. So the quality of the DEXA is also important for the benefit of the patient, obviously. But then when we go to the bone health assessment, then we have several arms. First of all, we define the patient with the BMD categorization: normal, osteoporotic, osteopenic, osteoporotic. Then you would characterize the patient with the TBS categorization: good structure, partially degraded structure, or degraded structure. Then you will combine those into what we call either bone resilience or bone fragility index, where you see that you will take into account both the density and the structure, and then identify in which level of risk am I ending up with my patients. So maybe you will identify the patient, oh, my patient is a high risk. But the following question of the clinician is not, okay, they're high risk, so what? The question is, should I treat or should I not treat? But then if you decide to treat, how should I treat? And then after, how long should I treat? So if I go briefly to these steps, so should I treat? You remember I mentioned about the FRAX adjustment by TBS or the BMD T-score adjusted by TBS. So if you take those patients in this category of risk and you apply either the FRAX or the TBS, if the FRAX adjusted by TBS is above the intervention threshold as defined by IOF, for example, or if the BMD T-score adjusted by TBS is below minus 2.5 or minus 3, then you will feel confident enough to say my patient is sufficiently high risk to treat. Then the following question, how should I treat? You remember I show you there is an algorithm based on FRAX from IOF, just telling you, well, depending on the level of risk, you may want to go for more severe drugs or less severe drugs. Let's go one step further. And I show you the graph where some drugs increase the microstructure, some other not, some other maintain, some other not. So let's put here is like a map of treatment according to the profile of risk of the patients. Obviously, if you have a low density and a low structure, you say, let's boost the structure and the density, so I will go for stronger drugs. Now, if you are here, you are osteopenic and the degraded structure, which of the drug can impact both? Denosumab, for example, the Prolia. So you will then start by having 1 year of biphosphonate if you're not a primary intention drug, or to avoid the rebound effect at the second stage. And then after you switch to denosumab, and you will try to treat the patient for the structure of the bone. Now, how long you should treat? That's a decision that you have to make with the patients. Because at the end, the patient partner, I told you that 50% of the patient will drop the treatment after 18 months. That's huge. While we know most of the efficacy of the drug is after 2 or 3 years. So the idea is to help the patient to choose the pathway to go to a lower risk zone. In other words, my patient is here. Do you want to go out of the high risk zone rapidly or not? Well, in that case, you want to go out rapidly, then you want to take anabolic drugs or potentially a denosumab or depending if you have a fracture, no fracture and so on. But now if the patient says, no, I just want to biphosphonate. Okay, we can give you biphosphonate. You will not improve the microstructure. You will have to improve the density, but it will take longer time to get out of the high risk zone, meaning you will have to treat maybe 5 years, 6 years, or whatever to get the patient at a lower risk zone. And when you get outside the high risk zone, you will reassess the level of risk, potentially change the treatment, or potentially have a drug holiday for a while before retreating, and so on. So everything that I mentioned about the FRAX, adjusted, TBS, the combination, everything come into all-in-one report, fully automatic for the TBS software, including conclusions which are like being pre-established based on WHO definition and so on. Like within few seconds, you get a full comprehensive report. So now if I take one clinical example, and that will be almost my last slide. If you have a patient here, which is 62 years old, with no fracture, she's smoking, the BMD T-score at the lowest risk is she's osteopenic. Okay. The laboratory unrevealing, no major issues. TBS, fairly low, like degraded structure. So we go through the BMD T-score and say, okay, osteopenic, very low. So what could have triggered a fairly good density at this age? Current smoker and degraded structure, which is fairly low. Well, we check we test for the diabetic. And the patient was borderline, she was pre-diabetic patient, really borderline. We know from the studies, and a lot of study in TBS in the guideline for diabetic patient now, if you have a patient which is pre-diabetic or diabetic with a bad control of HbA1c, what will happen? The structure will be degraded while the density is normal or supranormal. So at the end, we say, okay, we should treat it. Can we treat? We check for the FRAX adjusted by TBS. according to the Swiss threshold? No, it was just under the intervention threshold. According to BMD adjusted TBS? Oh, it is. So we were able to treat the patient according to IUF diagram of patient administration. So I will end it up by just saying one word on this, and that will be a question answer if you have any. Is really that we're also developing is, I told you in the introduction that 70% of the people never been referred to the XA while they're at high risk. So what we developed, and also with the collaboration of Giuseppe, is that we do a screening, opportunistic screening using AI based on density and TBS, so that when you have an incidental finding, if you have a back pain, you go for an X-ray, we will flag the patient on the back end saying, hey, be careful, you have a very high risk of osteoporosis, you'd better go to a DEXA examination, DEXA for BMD and TBS, and so on.
So I hope that this very comprehensive talk was able to demonstrate the different role of the TBS. In fact, starting from the diagnosis, helping the radiologist to the diagnosis, then move in order to establish the risk of fracture, and then finally this system can be used to monitoring the therapy and to control, the effect of therapy. And in our experience, we really have seen the difference using this approach in evaluating different kind of patient. For instance, I like to remember how is important the impact of this evaluation in patient with secondary hyperparathyroidism, people that undergo dialysis. And then in this patient, the BMD is the same normal value that in a normal subject. But when you use this new approach, you can see the difference, because we are talking about different type of bone, not normal bone, but osteoid bone. That means the difference. And TBS is able to evaluate the porous structure of bone. So with this system, we really make the difference, and I believe that has a great impact in the daily clinical practice. So I really have the feeling that this system should be adopted in the management of patients with osteoporosis. And in fact, in our international society, I'm talking about International Osteoporosis Foundation, SCEO meeting, and Italian Society of Metabolic Disease, the system is largely used, and the many papers written on this confirm. And in fact, we published recently a paper together analyzing the impact of the system in different conditions, and the result was positive in all cases.